Today we are going to talk about a very important pathological condition which happens in our body. This is known as the thrombocytopenia. This is a combination of the three words, but we can make them two words. Thrombocytes is the medical name of the platelets and penia means deficiency. So this is a pathological condition which is somehow related with the decreased concentration of the platelets in the blood. So the definition of the thrombocytopenia is any platelet level which is less than 150,000 per cubic millimeter. Normal value of the platelets in the blood is 150,000 to 450,000 per cubic millimeter, and whenever the concentration or the amount of the platelets in the blood is less than 150,000, we call it the thrombocytopenia. But clinically speaking, any level which is less than 50,000 or less is important, or whenever we are planning to go for a surgery, any level which is less than 100,000 per cubic millimeter of the platelets is important. Talking about the causes or etiology of the thrombocytopenia, these can be broadly subdivided into three categories. One is when there is no production of the platelets in the bone marrow. Secondly, they are produced in the bone marrow, but these are destroyed in the peripheral circulation. And thirdly, whenever there is a spleen enlargement, then there is a sequestration of the platelets within the spleen, or they are separated from the circulation within the spleen. So talking about the causes of the thrombocytopenia, in which we do not see either proper or production of the platelets in the bone marrow, or there is no production of the bone marrow of the platelets. So there are 10 most famous causes, and these are the radiation exposure of the patient to some cytotoxic drugs like the chemotherapies, certain group of the viruses which can cause the thrombocytopenia as a result of impaired production of the platelets in the bone marrow. It can be the megaloblastic anemia, leukemia, myeloma, myelofibrosis, or it can be the myelodysplastic syndrome, aplastic anemia, and lastly, the solid tumor infiltration of the bone marrow. Talking about the causes of the thrombocytopenia, where we see the peripheral destruction of the platelets once they have been produced in the bone marrow. These are the autoimmune diseases like the immune thrombocytopenic purpura. There are certain drugs which can cause thrombocytopenia by destruction in the peripheral area. These are the glycoprotein 2B and 3A receptor inhibitors and the penicillins and thiazides. Also includes are the heparin along with these drugs. Then there can be systemic lupus erythematosus, or very famously known as the SLE. It can be the chronic lymphocytic leukemia, or CLL. There are certain viruses which can cause the peripheral destruction of the platelets. It can be the post-transfusion purpura, where we see that when someone is transfused, then it contains the antigen-antibody reactions which can cause the destruction of the platelets and formation of the purpura or the blood spots underneath the skin. And lastly, it can be the thrombocytopenic purpura. Now the last very important reason for the development of the thrombocytopenia or the decreased platelets in the body will be its sequestration or separation in the spleen. It can be because of the two conditions of the spleen. Either the spleen is enlarged in its size, so it will retain a lot of platelets in it, or the functioning of the spleen can be more than the normal, which we call the hypersplenism. So this is the third cause, but the fourth important cause can be when we give the massive blood transfusion to any patient, or we give the IV fluids, then the patient will develop the dilutional thrombocytopenia. The topic of interest in this video, this is going to be the immune thrombocytopenic purpura, which we call the ITP, and the thrombotic thrombocytopenic purpura, which we call the TTP. In both of these conditions, some things are common. For example, both are related with the peripheral destruction of the platelets. Secondly, there is a word we call the purpura, which is present in both of these conditions. This is a blood spots underneath the skin, so it will be present in both of these conditions, and both have got the thrombocytopenic, which means the blood platelets will be less than 150,000. In one of the condition, the former one, which we call the ITP, it's the immune system which is playing the major role. But in case of the TTP or thrombocytopenic purpura, something is related directly with the thrombosis or the process of clot formation within the blood vessels. Talking about the immune thrombocytopenic purpura, the general facts are that there is the immune destruction of the platelets. The platelets, first they are coated with the antibodies which are generated in the body, and these antibodies coated platelets then are presented to the FC region of the macrophages, which engulfs the platelets and finally destroy these platelets to cause the thrombocytopenia. Talking about the immune thrombocytopenic purpura in the children or the pediatric ITP, most of the time these are the patients which fall in the category of the age of 2 to 6 years, and it has got an acute onset, and there is a history of recent infection with the varicella or measles infection. Clinically, these patients do not most of the time present with the life-threatening hemorrhages, but they do come with the mucocutaneous bleed, which can be sometimes very brisk. This is a diagnosis of the exclusion. You need to exclude other causes of the thrombocytopenia. On the peripheral examination, there will be decreased platelets, but you may need to have bone marrow examination to confirm the diagnosis, because you may find either the normal or increased megakaryocytes, because there is no problem with the bone marrow, but there is a problem with the destruction of the platelets in the periphery. What can be the probable treatment of the ITP in the children? It can be the corticosteroids, like they can put on the prednisolone. Patient can be put on the immunoglobulins, which has got a much better response, like the immunoglobulin G. You may need to use the anti-D in these patients who are children and had developed the pediatric ITP. In case of the adult immune thrombocytopenic purpura, these patients have got not the acute but the chronic immune thrombocytopenic purpura. It's chronic in duration, and it happens more in the female and less in the male. The female which develop ITP, they have got certain associated autoimmune diseases, which are the SLE, thyroid disease, autoimmune hemolytic anemia, which is also known as the Evans syndrome, chronic lymphocytic leukemia, and there are certain solid tumors which are associated with the ITP in the adults. Platelet autoantibodies, they are positive in more than 70% of the cases, and whenever we get bone marrow examination in these patients, we either have a normal or we have got increased number of the megakaryocytes. The clinical presentation in these patients, mostly they present with the easy bruising. They very easily get bruises. They develop bleeding from the nose or the epistaxis. They develop the purpura or the bleeding underneath the skin. They are hemorrhagic or the menorrhagic rather. They have developed excessive bleeding during the menstrual period. Their treatment, other than the supportive, is the corticosteroid. We can use prednisolone in them, 1 milligram per kg per day. We can also use the immunoglobulins like the immunoglobulin G. There is an option of removing the spleen so that the sequestered platelets, they can be brought back to the circulation. We can use the anti-CD20 receptor antagonist like the rituximab, and we can transfuse platelets in these patients who have immune thrombocytopenic purpura and they are adult patient. And lastly, we can also use the thrombopoietin receptor agonist, and one of the good example is the romiflostim in these patients. Now, talking about the thrombotic thrombocytopenic purpura, it's a very rare but very serious condition. and there is platelet consumption which leads to the thrombocytopenia. So there is no platelet destruction like it was in the ITP, where the platelets were antibody bound, but here there is increased use of the platelets which leads to the decreased concentration of the platelets in the body. What is the pathogenesis of the TTP or the thrombotic thrombocytopenic purpura? There is a protease which we know with the name of the ADAMTS13. ADAMTS13 is a protease that actually decreases the size of the ultra large von Willebrand factor or VWF. Normally these are very large, and this protease does a very important function. It cuts down the size of the VWF or the von Willebrand factor so that these become hemostatically very fitting for the platelets to be attached, and this is how the process goes on. But whenever there is a decrease in the ADAMTS, either because of the defective gene which is encoding this protein, or because of the antibodies which are formed against this protease, which we call the ADAMTS13, whenever there is a deficiency, then you will have a large number of the ultra large von Willebrand factor. And when the platelet combines with these, there will be two changes. One, there will be the endothelial damage, and then there will be microvascular thrombosis or multi-organ microthrombi, and that will also lead to the hemolysis. The clinical feature of the thrombotic thrombocytopenic purpura will be there will be the florid purpura, fever, there will be fluctuating cerebral dysfunction, patient will develop the hemolytic anemia, and there is acute kidney injury. Because of the microthrombi formation, there will be acute injury to the kidney. What test we get? To diagnose and monitor, we get platelets which are less. That is why we call it the thrombocytopenia, and we will also get the lactate dehydrogenase. Now this lactate dehydrogenase increases because there is a increased hemolysis which generates lactate dehydrogenase. So not only it helps to diagnose the case, but it also helps to monitor the prognosis and the success and failure of the treatment. So what are the treatment options in case of the TTP? We have platelet transfusion. They are contraindicated. This is very important difference between the ITP and TTP. In the ITP, we did use the platelet transfusion, but in case of the thrombotic thrombocytopenic purpura, where there is a consumption of the platelets, if we give transfusion of the platelets, this is as if we are adding fuel to the fire. So platelet transfusion is absolutely contraindicated in cases of the thrombotic thrombocytopenic purpura. We use the fresh frozen plasma, which are solvent detergent fresh frozen plasma, which contain the ADAMTS13. We can use the cryoprecipitate. There is an option of the plasma exchange which removes the autoantibodies against the ADAMTS13 and improves the concentration of the ADAMTS13 in the body. We can also use the pulse therapy of the IV steroids like the methylprednisolone, 1 gram. We can give 1 gram for 3 days. We can also use the anti-CD20 receptor, which is the rituximab. There is also option of the immunoglobulin, which we know as the caplecizumab. So we can use these options for the management of the thrombotic thrombocytopenic purpura. Thank you so much for watching the video. Now if you like the video, then please subscribe the channel and hit the bell icon. And if you do not like the video, then for the time being, please do not subscribe the channel, because once the quality of the video and the channel improves, you will definitely subscribe the channel. Thanks again for watching the video.